So we have time for one quick question. If there is one. All right. If there's not, we will move along. Thanks very much, Charles. So our next speaker is Jeremy Sugarman. Jeremy's a professor of bioethics and medicine at Johns Hopkins, and is going to talk about ethical considerations in determining, disclosing reasonable, foreseeable risk.
Great. Thanks so much. And I'm going to go without PowerPoint today. Figured one more thing to get you right after lunch would to keep you a little bit awake, perhaps. So I've spent the last 20 years or so working on questions of research ethics. And the conversation we heard this morning reminds me of lots of conversations I've had over the last 20 years. And most of the solutions to problems in research ethics tends to be heaping on additional protections or procedures to put them into place because something went wrong. Something happened that we couldn't predict. What I've been challenged with more recently is some work with standard of care research through work on the NIH Healthcare Systems Research Collaboratory and the PCORNet Ethics and Regulatory Task Force to take on the kinds of trials that we're thinking about, not the study which shall not be mentioned, but another range of studies, a series of studies that we're conducting within the Healthcare Systems Research Collaboratory and the ones that PCORNet is thinking about moving forward. And this challenge has been one of asking the question, are there things that we're not doing so well? Are there things that we can take away? What do we really need to protect the rights, interests, and welfare of participants? All that said, of those people I've talked to and my colleagues at the Berman Institute, these thoughts are mine, so have at me, and I'm sure Len and Ruth will later. So when we think about the guidance document, the notion of standard of care, notice that in the document, sometimes it's standard of care, sometimes it's standards of care. Sometimes Jerry Menikoff spoke of it as standard of care and sometimes standards of care. Alta offered competing definitions of standard of care. Some people are coming at it from the law, some are coming at it as a regulatory matter. We need clarity at the beginning of a policy document about what we're talking about. Within the context of care that's being delivered in the healthcare setting, within the standard of care, I would assume that standard of care are the range of practices that are acceptable, not different standards of care. And part of the debate, to add to what Charles's confusion was, is that as a scientific matter, people think of these as all consistent with the standard of care, not a standard of care. And we need to get that matter right if we're going to get a guidance document right. As an ethical and empirical matter, we also need to disaggregate standards of care for whatever interventions are being tested and standards of care for disclosure and consent. Those are separable issues, and we need to treat them as such. If we mix them and muddle them, other than sort of the regular edicts that we have to follow, we're going to be confused. And another background issue is that all standard care research is not equal. It's not like Lake Wobegon either, which some is more equal than others, but there are qualitative differences which have been confusing the conversation and the discourse around this. A surgical intervention versus a medical intervention is a qualitatively different subject. It's not a risk. It's a qualitatively different intervention which warrants a robust discussion, consent process, and the like, because they are very different things. In contrast, a medication versus a medication that's got a similar use and indication, but we're not certain of which way to move forward, is a qualitatively different kind of study where it may not make sense to throw on all our research protections. In addition, another qualitative difference in the kind of research we're talking about is comparative effectiveness research versus healthcare systems operations research. If this guidance moves forward without disaggregating those concepts, we're going to get really funny conclusions. We focused much of our discussion on CER this morning, but we have to be careful about the unintended consequences of a guidance that goes beyond its purview. Now let me just talk about risk for a second. Risk does not mean harm. Risk can be considered as part of under 45 CFR 46 and its relevant subparts in certain ways where harms are included. Risk is a chance of harm. And that really needs to be made clear in the guidance and in our considering this. Qualitative differences are not risks. They are qualitatively different research endeavors. Now, once we get to risk, there are three domains. Charles did a nice job of laying those out, but let's think about what the document says if we're going to be forced to examine it. There's a baseline risk of disease and conditions. Much of the research that's being done in standard of care research, whatever that really is, is predicated on measuring the things that happen to people anyway as a result of their underlying condition. To use those very same risks, they're not risk, there's what happens within those diseases, as measurement needs to be considered about whether that's the right tool to be used to make IRB decisions based upon them. Second are the baseline risks and benefits of the standard of care interventions. The guidance asks us to consider what happens differently to this person if they were to be in this study compared to standard of care. We heard a little bit this morning is, the fact is, we don't know. There's great practice variation. There's uncertainty of level of evidence. There's uncertainty about data use and collection practices, which the guidance doesn't go into terribly, but people are concerned about privacy. And the guidance assumes that clinical practice is okay, because we don't wear white coats so much anymore, and we're not supposed to wear ties because they cause infections, but somebody that sort of does those things that are doctor-like, aside a white coat and a tie, is helping out. All of those uncertainties make it difficult to apply the guidance as it's currently written. The incremental part of research I'm going to leave out because I think component analysis there can be helpful to us in that regard. So let's think, too, about another difference of standard of care research, and that goes to the protections of practice. Unlike the situation of a novel agent being tried for the first time, standard of care research has, if at least done in a pragmatic way, the protections of practice. Patients can say, I don't like this. It's not as protocolized. A doctor can say, you're not getting better. We can change this. So the vision of a practice that changes and research that is embedded in practice also may change our intuitions about what the right thing is to do. So now let's move to reasonably foreseeable risk. How many people woke up this morning and said, a reasonably foreseeable risk of rain? A pleasant day in your nation's capital, right? So it rained, but it stopped during lunch, but we didn't have time during lunch to go explore that, okay? But I'm not sure why. So when the document asks us and the regulations ask us to say reasonably foreseeable risk, they're not asking us to do all risks, right? Or they would have said all risks. Looking at current consent documents that many IRBs approve after they pick their favorite font is there's another risk you left out. Let's heap that in there too. More information has to be better, right? No, it doesn't. So it's reasonably foreseeable. If you look in the Federal Register, notice, and there's a description about some of the comment periods, OHRP responds that they don't want to use the notion of frequency. Well, reasonably foreseeable. I would say, as a rebuttable presumption, reasonably foreseeable are those things that happen more frequently. Right? So I'm not sure how that conclusion was reached, but I think we need to pay some attention to that. And we also have to remember that despite how wise and reflective we are after bad things happen in trials or good things happen in trials, that we all of a sudden understand different risks. Risk must be determined by an IRB and a prospective research participant prospectively. After it happens, it was either a harm or it wasn't a harm or it was a benefit. It's no longer a risk. Finally, more information isn't better. Patients and potential research participants don't want all risk information. Kevin Weinfurt will describe some of the data we've been gathering through an empirical study later today, which will show us that patients don't want all risk information. They think it's too much, and there are paradoxical effects of information. Sometimes by providing a lot of risk information, you can have unintended consequences that make the research appear riskier, yes, this time intended, riskier than it otherwise really is. It's also important to remember that not all the risk information ought to be included in a consent document, will be included in any conversation, in any doctor-patient relationship. It's going to be truncated and then tailored to what patients needs. You know what? Patients do a lot of research before they come to clinic and when they make decisions. They talk to people. There's this thing called the internet, and they go out there and they use it. And there are other people involved in the process. A drug is prescribed, and the doctor doesn't go through all of that, but the pharmacist does, and the patient information sheet provides that. There are multiple sources of information that patients tap and use and will use and should be encouraged to use so that they can make informed decisions along with the clinicians, not one anymore, not for a long time, good thing, that they can use. So, I just want to close with 2 points and then just a couple of suggestions. 2 clients is that disclosure and authorization, as I mentioned at the front end, ought to be considered separately, consistent in the way that it's done in practice. When we engage in very risky endeavors with patients, or there's a special rule or law that documents, we go through a fully outlined consent process. In most settings, it's more, as Ben characterized this morning, more of a shared medical decision-making practice, giving some information, hitting the main points, the reasonably foreseeable risks. But you know what else? The reasonably foreseeable benefits. We don't start the conversation with, I'm going to give you this poison, and here are all the bad things. And by the way, if you take that, your asthma is going to get better. Right? So the goal of the enterprise is, I'm going to give you this. This is what we expect to happen. Do you notice that the word benefit doesn't appear quite as frequently as the word risk in this document? What are the benefits to patients, to society, to science? The IRB has to balance those things, and benefits needs to be considered along with risks. So my final comments. I think we're right. The evidence base for clinical practice needs to be enhanced. I know we're happy with the health care we receive. Everybody's thrilled, right? But we need to improve the evidence base. For those of us that practice medicine and those of us that read about it and hear about it, we need better data to drive practice. And some of that research is not as sexy, it's not as interesting. The aspirin question is a hugely important question. No drug company is going to pay for that study. And it needs to be done because it can save, the information stands to save lots of lives. None of these comparing different known agents. They need to be studied so we can deliver better practice. We have to do so without abrogating the rights, interests, and welfare of patients and other stakeholders in the process. Standard of care guidance needs to acknowledge that one size doesn't fit all. When there are qualitative differences in interventions, we need to get consent. We need to have a big conversation. Whether that's, as Bray pointed out, side effects matter. They matter deeply to people. And so if those are the kinds of differences that are being explored, we need to get consent. If we're doing surgery versus a medication, we need to get consent. But we can also truncate it when the differences are not qualitatively much different. We've been able to navigate some of these issues within the current regulatory framework within the Healthcare Systems Research Collaboratory. Doing so took elaborate conversations with multiple stakeholders in order to come at what the appropriate approach is, and we stand to learn from those situations. But each of the trials that waived consent or modified consent to be more akin to what it would be in clinical practice when the risks, the reasonably foreseeable risks, are not great, required a minimal risk determination because those minimal risk determinations were justified. But there may be other research where a minimal risk determination is not possible and we're stuck. We can't move forward as a regulatory matter. That's a problem. That's a problem that needs to be addressed. What can we do? Well, I would make a call. Here's my Hail Mary pass here. We could do demonstration projects. We could learn what happens. We don't have to assume that I'm the patient and this is what I would want, or any panelist or any speaker assumes they're the patient. That's not a patient. We'll give you more systematic data later. We're gathering more of it about what patients as a denominator want, not rhetorically gifted patient surrogates. Okay, we will give you systematic information and we're going to try to provide it, but we ought to do some prospective demonstration projects. How would we do it? Secretarial waiver. That's let's try one of those. That hasn't been done. That'd be fun. It's a good thing, parting shot on the way out, you know, why not try it? And it's beyond the scope of this panel. I'm wondering why we're pausing to consider this particular issue when we're still waiting for a prospective notice of rulemaking, because we're going to have to revisit this issue again, and it may make sense to do this all at once so that we can get it right and we can do it within the system that we're going to live with in the future. Thanks for your attention.